Hello, and welcome to this edition of Oncology Data Advisors coverage of the Oncology Nursing Society ONS Congress 2025. Thank you so much for joining us today, Ms. Uranga, to talk about your presentation at ONS this year. We're very excited. Would you like to begin with a brief introduction of yourself and what you do?
Thank you very much, Lynn, for inviting me. I'm very happy to talk about older adults. That's one of my passions. I'm an adult gerontology clinical nurse specialist by training, and I've worked in oncology at a comprehensive cancer center pretty much all my nursing career. And maybe 10 years into my bedside nursing, I decided to, you know, go ahead and get my master's and wanted to really focus on older patients. So I'm really passionate about improving care of older adults with cancer. And I'm going to talk to you about my presentation I did at the 50th Annual ONS Congress in Denver, Colorado last month.
Definitely, we're excited to hear more about it. So, would you like to start with telling us about your presentation?
Sure. The name of the presentation is What's Age Got to Do with It? Caring for Older Adults with Cancer. I really like the name. My ONS coaches made that title, and I think it's perfect. So if you may not know, but older adults are estimated to make about 20% of the U.S. population by 2030. There are also a lot of cancer survivors, and those are projected to increase from 18.1 to 26 million by 2040. So we not only have adults with cancer, but we also have survivors, and we may need to provide ongoing specialty care to keep them healthy. These stats have been the writing on the wall. That tsunami has come, that silver tsunami that people talked about. So it's important that oncology nurses start to integrate some geriatric tools, geriatric assessment tools into the practice so that they are providing optimal care and also improving care of older adults with cancer. So basically, what I wanted to do is spark a little bit of interest in becoming a gerontology engaged resource oncology nurse or a gero nurse um, with my presentation at ONS.
So I did want to ask you, so what does age have to do with it? Why is it vital that we are understanding the unique treatment path for geriatric patients with cancer?
Oh, yes, it's very important. There is basically various age groups, and we seem to kind of put together adults in one group, whether they're, you know, 30 or 65 or 80. So one of the things I did with my presentation is I provided an overview of the various stages of life in three acts. So Act 1, Act 2, Act 3. I am in my third act. So to me, what's age got to do with it is, I'm thinking about as I get older. So I'll give you a little bit of information about how I did it with three acts. So Act 1 is ages 0 to 29, and that can go from children, young children to young adults and adults. And when we look at the incidence of cancer in this group, it's 3.7%, according to the SEER stats data. This age group has optimal physiological reserve. They have strong bones, they have strong hearts, muscles, physical energy, um, and they also often receive aggressive treatment for their cancer. And they're enrolled in clinical trials compared to older adults, very aggressively in the 60% range. Now going to Act 2, which is those adults that are like between the ages of 30 to 59, statistically, they do have more cancers, new cancers, and that's about almost 40%, 39.6, that compared to Act 1, which is like 3.7. And you also start to see some changes to their physiological reserve, especially toward the latter half of the Act 2 age range. And you start to see some chronic diseases such as heart disease, diabetes, hypertension. You start to have to wear your glasses so you can see small print. So there's physiological changes happening. However, this group does still receive a lot of aggressive treatment in clinical trials. There's more of them available to this age group. Now, Act 3, which is those that are 60 and older to about 89, their incidence is 56.8. So over 50%, almost 57% of new cancer diagnoses are in this age group. And the median age for this group is 67. So right around retirement, you start to see cancers in this group. The physiological reserve for this group is starting to go, it varies, but there's a lot of changes going on to various body systems. And also homeostatic mechanisms and immunological functions decrease in this age group. And then you really start to see changes with frailty or functional decline in those that are 85 and older, or the old. Um, with regards to impaired immunological function, for instance, increase in risk of infection like UTIs, pneumonia, and that sort of thing. There's more prevalence of autoimmune disease. There's also reduction in homeostatic mechanisms, and that's like temperature control and regulation. So you may see older patients wearing multiple layers to stay warm, or they may be more susceptible to heat stroke because of the regulation changes. There's also a lot of imbalance in fluid and electrolytes, and a lot of times you lose your diminish or your thirst sensation is diminished, so you don't drink enough water, and therefore your dehydration can be at risk. So if you are thirsty, it's because you're really dehydrated. And then there's other things like atypical presentations of illness, like we mentioned earlier about the risk for infection is higher. UTIs or pneumonia in someone younger may manifest as, high temperatures, pain for UTI. In older adults, you may just manifest as a confusion. They may become delirious. These are geriatric syndromes. So there's atypical presentations as you get older. So if you're thinking of someone who's younger, who's going to come in with pneumonia, with a cough, fever, that sort of thing. With an older adult, they may just be a little confused. There's also chronic illness. So older patients have more comorbidities like diabetes, hypertension, heart disease. And according to a study done by the Center for Medicare and Medicaid Services in 2012, comorbidities in those 65 and older could be as high as 68%. They may have two or more comorbidities, right? It could be 36.4% and have greater than four comorbidities. So on top of the cancer, they also have comorbidities. Lab values can also be tricky in this group. You should consider looking at the normal, the values that you think are normal, may be a little skewed, right, in those that are older. And then also medications, pharmacokinetics and pharmacodynamics. These older adults are prone to having many medications, five or more. We call that polypharmacy, and that could lead to adverse drug reactions, contraindications. And of course, the organ systems that are not as robust as they were young when you were younger, can also be impacted by the medications that you're taking, right? Kidney and liver function, which metabolize some of these medications, are not working optimally. And then there's also changes to activities of daily living. Their functional status could change. And this is so important for older adults, their quality of life. Can they dress themselves, feed themselves? Can they get out of bed? These activities are crucial for someone. And when you think about it, if you have a broken leg, your functional status has changed, right? And it creates quality of life issues. In older adults, they could be, they could fall, break a hip, and that could impact their activities or independent activities of daily living. So things get more complex when you're caring for older patients, and you have to consider all those things as you um, provide care for them, in your clinics, in your hospitals, and that sort of thing. I did have a couple of slides where I went into the various systems, and it wasn't comprehensive, but it just had little bit of information for cardiac, what happens with your cardiac system. Maybe your elasticity in your veins and in your arteries is not as robust as when you were younger. So there's things to consider cardiac wise as far as, you know, blood pressures, right? You're more at risk for orthostatic hypotension, meaning, you get up all of a sudden, you might get dizzy because your cardiac system cannot compensate as quickly as it did when you were younger. So I had some slides about that. So there's a lot of things that you have to consider with your older patients as you're caring for them.
With these differences, what are strategies clinicians could utilize when managing and treating older patients with cancer?
Yes, there's definitely things that, and one of the things I did go over with the group was thinking about a geriatric assessment. And a geriatric assessment is a basically a questionnaire, but it's self-reported, meaning the patient completes this questionnaire, and it has various domains such as, what are their goals, what social support they have, what is their psychological status, are they feeling depressed, are they anxious, What's their functional status? Have they fallen? How are they moving around? Medications, how many are they taking? Do they have any cognition issues? Is there any dementia that we should know about? Nutrition, um, are they eating? What is their weight? Is it within the normal range? Are they overweight or underweight? If they have any comorbidities, and this really helps us assess our older adults for vulnerabilities, and each domain provides a little snapshot of their concerns or issues specific to that. And all of these can impact the care trajectory and outcomes for their treatment, right? So, having a little bit of information, a little more holistic information about them could really help us figure out how we need to strategize. So, in the case of a patient who comes in and their geriatric assessment indicates that maybe functionally they have issues, and now you're going to give them a chemotherapy or a treatment that's going to make that worse. What can you do to help prevent or at least maybe be more proactive? So, if they're getting treatment that's going to make them really tired, should you consider having occupational therapy help them with fatigue management? So, those are the kind of things that, a geriatric assessment can do for those patients. And like I said, each domain has creates a snapshot, but it does it by using validated tools that help you identify those deficits or strengths so that you have better insight into that patient's situation. Maybe their social support is not good. So what are we going to do to get them to their treatments? Do they need, Uber rides? Do they need to be set up with transportation? Because they really don't have anybody who can bring them to their appointments. So, allowing the clinician to provide necessary interventions to improve deficits or vulnerabilities is crucial to making sure that they complete their treatment and be more informed about what this treatment is going to do and how it's going to impact their overall quality of life. And not only that, but the ASCO and NCCN have recommended that older adults receive or undergo a geriatric assessment to identify those vulnerabilities. And more recently, they also recommend that not only do you identify them, but that you provide some sort of geriatric assessment guided management. Again, what are those interventions going to be when you discover that they have certain issues or concerns that need to be addressed as they go through their treatment? There's two tools that are available. One from the Association of Community Cancer Centers. They have a really nice guide that you could use, and it has all the tools on there, all the interventions that you could do. Also, Caring for Older Adult toolkit from the Canadian nurses. That was a great tool. It's just more recently. And then we have the CARG geriatric assessment patient tool that's available on their website that you can actually, if you wanted to go in and actually maybe you have an older adult or a family member and you have them complete the form, at the end of it, it'll provide you with interventions. It's really very good to kind of find out what are those vulnerabilities and those deficits that you may need to work on.
I was going to ask you how clinicians could better incorporate recognizing age in their practice, but I think you've gone over that. But if you have any extra information, I'll ask you anyway how clinicians, could better recognize age in their practice in assessing treatment plans and goals and defining survivorship.
One of the things I did do in the presentation, which I thought was beneficial for those who maybe have never seen any kind of geriatric assessment, was I introduced them to a screening tool called the Geriatric 8. It's really just 8 questions, and the questions then could prompt you to say, hey, this patient needs a full geriatric assessment, maybe by a geriatrician. But if you don't have a geriatric, you know, maybe clinic, you could at least get some nuggets from that tool that will help you recognize some of these issues that come up with patients. And the tool itself has, like I said, 8 questions. It has a score. If they get less than 12, then that would be an indication that they need a more comprehensive geriatric assessment. But it's really easy to use. You're the ones that are asking the questions. It has many questions related to nutrition, mobility, how healthy they feel they are compared to other people, um, if um, if they've had any weight loss, do they have any issues with dementia? So just in asking those questions, you can get a whole lot of information from someone about maybe potential vulnerabilities that you can work on. Um, and this specific tool is for those that are 70 and older, which you can better hone in on that group. Because as I mentioned earlier, as you get older, you have more risk for getting cancer. 67 is the median age, but as you get older, that also increases.
Right.
That would be one thing I would help to allow you to better recognize these ages changes as they get older.
Since May is Older Americans Month, do you have any takeaway messages for listeners regarding age in caring for older patients with cancer?
Next time you care for an older adult, take into consideration if they have any issues or concerns. You can use the geriatric aid. There's other tools available too, like the Mini-Cog, which is more specific to gauging whether or not they have any cognitive impairment. I also showed this really quick sit to stand assessment during the presentation, where you sit in a chair, and for 30 seconds you do a sit to stand, and depending on how many you do, you could figure out if you have any risk for falling. um, I had a little competition going on with my people who were demonstrating it, but basically you could kind of see where are you at, with regards to the risk for falls. This is a really great assessment tool that you can use, and it could be done telehealth. Like if you were going to do this online, you could just have someone sit in a chair and give them the instructions and figure out how to do that. um, so you want to make those necessary referrals. Like if someone did a sit stand and they were at risk for falling, you could refer them to physical therapy, right? You could tell the physician, hey, they may need some physical therapy because they're at risk for falling. Again, if they've fallen once, or maybe they're just at risk. You could also even do something like a medication review, right? You could ask pharmacy to do that and look at that. So having an idea of what some of those issues could be ahead of time, you could then focus in on those areas, and seeing what you could go ahead and help your patient with. There's also one area that I also talked about, which I think is really important, and that's what matters to the patient. What are those goals they have for their treatment? Because if what you're going to do with regards to chemo, radiation, surgery, and it's not going to be within what they consider their quality of life, that's important to them, then you want to take that into consideration as you provide treatment. What's important to them? What are their goals for their treatment? Sometimes it's seeing my daughter get married. I want to get the treatment that's going to get me there. Or maybe it's, I want to be sure that I stay at home as long as possible. What's going to provide that for them? Because ultimately it's what's important to them and what matters to them that we have to really be attuned to.
Thank you so much for your passion on this topic and bringing it to ONS and now sharing it with our audience. We really appreciate it, and we appreciate your time today. Thank you so much, Ms. Uranga.
Oh, thank you very much. It was great talking about this topic. So what's Gage got to do with it? Well, there's lots of, so I hope you learn more after this presentation.